So today we'll start with edema, congestion, hyperemia and hemorrhage. So what all we'll cover today? We'll see the normal fluid circulation. I think you'll have some idea about it from your physiology knowledge. Yeah. Then edema, a little bit about hemodynamics and disorders of hemodynamics, namely hyperemia, congestion and hemorrhage, and the recall session. Okay. So first we'll know what is the normal tissue fluid circulation. So under the normal circumstances, the blood which is passing through the capillary beds, in it the proteins in the plasma will be retained within the vasculature, and there will be little to no movement of water and electrolytes into the tissues. Okay. So as you can see here from the image, that this is the blood vessel, wherein inside we have the blood plasma. It is a constituent of the extracellular fluid compartment, and we have the other component, the intracellular fluid compartment. Okay, did you guys read about it in physiology? Yes? Okay, so you already know that there are two fluid compartments, the intracellular fluid and the extracellular fluid. So in the extracellular fluid, we have the interstitial fluid, which has the lymph as well, and the intravascular fluid or the blood plasma, some of it in the mesenchymal tissues, and a constituent of transcellular fluid. So we have to remember one thing, that the essential difference between the two main subdivisions of extracellular fluid, which is the higher protein content in the plasma than in the interstitial fluid, plays an important role in maintaining the fluid balance. Are you aware about this concept? What do you mean by fluid balance? That there is no fluid accumulation in the interstitium. Okay. So how is this maintained? We have majorly two pressures enacting on the vessels. One at the arterial end, which is the hydrostatic pressure. Another one at the venous end, which is the plasma colloid osmotic pressure. Okay. So the hydrostatic pressure, it is higher at the arterial end. So what it does? It pushes out the fluid from the vessel into the interstitium. Okay. So now that the fluid is going out, we need another counter pressure, which will cause reabsorption of the fluid in order to keep the interstitium dry. So that pressure is the plasma colloid osmotic pressure. Okay. So even after the enactment of these two pressures, there might be some fluid in the interstitium that is reabsorbed into the lymph. Okay. Is it clear? So the net result has to be, there has to be very little fluid in the interstitium. Clear with the concept? Okay, so here this is another diagram which explains it further. So there is filtration at the arterial end and there is reabsorption at the venous end with no net movement in the mid area. Clear? So what will happen if either of these pressures are not maintained? What do you think will happen? Yes? There will be collection of fluid in the interstitium. Now can you tell me which pressure has to increase? The hydrostatic pressure has to increase and the oncotic or the osmotic pressure has to reduce. So what will happen in that case? There will be collection of fluid in the interstitium, and this phenomenon is only known as edema. Okay. So now not only in the interstitium, this fluid can be collected in the different body cavities as well. So when it is collected in the thoracic cavity, it is called hydrothorax. In the pericardium, it is called hydropericardium, and in the peritoneum as the hydroperitoneum, commonly known as ascites. Now what is anasarca? When there is severe and generalized edema with profound subcutaneous tissue swelling. Okay, please remember this term, anasarca. So we've already discussed this part about the two pressures. the difference in which can cause or lead to edema. One is there will be increase in the hydrostatic pressure, pushing more of the fluid out, then decrease in the osmotic pressure, which will cause reduced reabsorption. Now another it can be there will be increased capillary permeability. What do you mean by that? Capillary permeability, the word is itself self-explanatory. Increase in the movement of the fluid through the capillaries. So when do you think it will happen? Here. You can see the membrane is continuous here, right? And there is disruption of the same membrane at this end, which is demonstrating what? When can the continuity be disrupted? Disruption of the membrane, inflammation or injury. Okay? And the third is impaired lymphatic drainage. So we know that whatever little fluid gets collected in the interstitium, that is absorbed into the lymph and is moved into the thoracic duct. So if there is an impaired transport of the lymph through the lymphatic vessels, then again we can have accumulated fluid in the interstitium. Clear? So first is increased hydrostatic pressure. So here we know that at the arteriolar end, the hydrostatic pressure is more in comparison to the venular end. So what happens? From the arteriolar end, the fluid moves out into the interstitium. Okay? So when there will be an increase in this hydrostatic pressure, there will be increased movement of the fluid into the interstitium, leading to edema. Is this clear? Yes? We'll move on to the pathophysiologic categories. So when will this hydrostatic pressure increase? One is it can increase because of dilatation at this end. Okay, arteriolar end. So when the vessel will dilate at the arterial end, there will be more inflow of blood and more extravasation of the fluid. Okay. Next, another cause can be that at the venular end there can be congestion or there can be constriction. So if there is constriction, there will be accumulation of fluid, more fluid within the vessel and leading to more movement of the fluid into the interstitium. Okay, so accordingly they have classified it. In the impaired venous return, we have causes like heart failure, pericarditis, cirrhosis and thrombosis and external pressure. Along with that, lower extremity inactivity with prolonged dependency. Okay, and in dilatation, we have causes like heat or neurohumoral dysregulation. Is this clear? Where in what all cases there will be an increase in the hydrostatic pressure? Okay. Yes, is this clear? Like there can be dilation at the arteriolar end or constriction at the venular end. Okay. So next is the decreased plasma oncotic pressure. There will be lowering of the plasma oncotic pressure and it will no longer be able to counteract the effect of hydrostatic pressure, leading to an increased outward movement of the fluid from the capillary wall and decreased inward movement of the fluid from the interstitial space. Okay. So we'll have reduced proteins. This will cause a decreased oncotic pressure, osmotic pressure. So if one of the pressure is reduced, then the other pressure cannot be counteracted. So if the other pressure is not counteracted, there will be an increased movement of the fluid into the interstitium. So, along with that, there will be decreased reabsorption of the fluid at the venular end, leading to edema. So what are the causes? They can be seen in protein losing glomerulopathies like nephrotic syndrome, liver cirrhosis, malnutrition and protein losing gastroenteropathy. Okay. So we have covered the two pressures which will lead to cause an edema. Okay. So next can be another cause for edema is sodium and water retention. So we know from the name itself that because of an increased salt retention, there will be an obligated retention of the water as well. So what will happen? both increase in the hydrostatic pressure because of increase in water retention and because of an increase in the fluid volume expansion, and there will be diminished vascular colloid osmotic pressure because of dilution. This both will lead to edema. Okay. So what are the causes? Sodium retention can happen in excessive salt intake with renal insufficiency, and there can also be increased tubular reabsorption of sodium in cases like renal hypoperfusion. Where can you see renal hypoperfusion? That means reduced blood flow to the kidney. In which cases? Renal hypoperfusion. The blood flow will itself be reduced to the organ. So which is the organ which pumps out blood? Glomerular? That will be local cause. When the glomerular injury happens, that will be local cause. Because of that, there will be loss of protein. Sorry? Yeah, blockage in the renal artery. And another cause, more systemic. Yes, in cases of congestive heart failure. So in case of congestive heart failure, there will be hypoperfusion of all the organs, including that of kidney. Now, another cause is the increased capillary permeability. So we already know that in intact capillary endothelium, it will allow only minimal passage of plasma proteins normally. But when the capillary endothelium is injured, the permeability to plasma proteins will be enhanced, and it will cause leakage of the plasma proteins into the interstitial fluid. Then what will happen? It will reduce the plasma oncotic pressure. So if more proteins will move out of the plasma to the interstitium, then the oncotic pressure of that of the vessel will reduce. Okay? And there will be an elevated oncotic pressure of interstitial fluid, all resulting in edema. Okay, so we are clear with all the causes. What are the causative or the pathogenic factors which can lead to edema? Okay, and this capillary permeability, we can see it basically in inflammation, both acute, chronic, and sometimes in angiogenesis. Why do you think in angiogenesis there is going to be increased capillary permeability? What do you mean by angiogenesis? Formation of new blood vessels. So why do you think in angiogenesis we will have increased capillary permeability? Yes, correct. Because they are new forming blood vessels, they will be immature and will have gaps between them. So this will cause movement of the proteins. Okay. Next is lymphatic obstruction. So normally the interstitial fluid in the tissue spaces, they will escape by way of lymphatics, and any obstruction to that outflow can also lead to edema. So what are the causes? They can be inflammatory, neoplastic, post-surgical, and post-irradiation. Okay. So few examples are, can anybody tell me which condition this is? Elephantiasis, that happens because of? Sorry? Filariasis. Filariasis, okay, we'll see that in filariasis. This is, can we appreciate this dilated white tracts? Yes? Can you appreciate? Is it visible? So this is the cut surface of a lung with carcinomatosis. This is showing dilated lymphatic channels because of metastasis through lymphatics. Okay? And this is a case of, as you can see, lymphedema because of post-surgical complications. As you appreciate, the patient underwent mastectomy, and with mastectomy, this is a very common complication. Now you remember the causes of lymphatic obstruction? Yes? So what is the clinical importance? Why should we know? The effects of edema, they can range from annoying to basically fatal, and subcutaneous tissue edema, which is appreciated in cardiac or renal failure, is important primarily because it signals the underlying disease. So in cases of cardiac failure and renal failure, patients will often come with the complaint of only edema. Okay, subcutaneous edema. So according to that history, we have to evaluate the patient and often reach the underlying disease. In pulmonary edema, it can cause death not only by interfering with the normal ventilatory function, but the fluid collected in the alveolar septa will impede with the oxygen diffusion. Okay, so the oxygenation will not be proper and the patient will often have complaints of dyspnea. Okay, and in brain edema, it can be serious and often fatal. So if severe, there will be herniation. Okay, so remember, cerebral edema can often result in herniation. Now we'll know about a few important forms of edema which are organ specific. First is renal edema. So in cases of renal diseases, the edema is seen usually associated with two conditions, either acute nephritis or nephrotic syndrome. So how are they different? The degree of anemia in acute nephritis is slight, but in nephrotic syndrome is marked. Okay. So in acute nephritis, what happens? There is usually glomerular injury associated. Okay, so if there is glomerular injury associated, there will be problem with filtration and there will be retention of fluid leading to edema. So it is because of which cause? Which pressure will be increased? Increase in the hydrostatic pressure. Now contrary to that, in nephrotic syndrome, it is a protein losing condition. Okay, so there is reduced protein. So what will happen? Which pressure is associated? Osmotic pressure. There will be, what will it be, reduced or will it be increased? Yes, there will be reduction in the osmotic pressure. And in acute nephritis, remember, the edema often begins in the periorbital region, okay, around the eyes. But in nephrotic syndrome, it will be generalized, like the entire face of the patient will be affected. It will be swelling and it usually affects kids. Next is cardiac edema. So in cardiac edema, the cause is congestive heart failure. What will happen in congestive heart failure? We'll have three important parameters. One is increase in the central venous pressure. So increase in central venous pressure means, which one will increase? It's written here already. Capillary hydrostatic pressure. You remember the arteriolar end and the venular end. So if there is congestion at the venular end, there will be increase in the hydrostatic pressure. And this will lead to back pressure hypothesis resulting in cardiac edema. Okay. Next, in congestive heart failure, there will be reduced cardiac output and there will be hypovolemia. So with hypovolemia, what will happen? There will be renal hypoperfusion and this will lead to activation of the aldosterone, reduced GFR and activation of the antidiuretic hormone. So what will all these do? This will cause renal retention of sodium in water resulting in cardiac edema. Then again, in congestive heart failure, we will have hypoxia, right? So hypoxia is a, what is that? It's a stimulus for injury, right? So resultant, there will be injury and increase in the capillary permeability resulting in cardiac edema. So you have to remember, in cardiac edema, we have increased capillary hydrostatic pressure, sodium water retention and increased capillary permeability resulting in edema. Okay? Okay, next is pulmonary edema. So pulmonary edema, as you can see, there will be accumulation of the edema fluid within the alveolar spaces and also in the interstitium. So what all can be the causes? There will be an increase in the hydrostatic pressure or there can also be injury to the basement membrane resulting in increased movement of the fluid and accumulation of the same in the alveolar spaces and the interstitium. Okay, clear? Now how will the microscopy be? So as you can see from the schematic diagram and also from the microphotograph, there will be congested blood vessels and will have alveolar spaces which will be filled with this eosinophilic granular edematous fluid. Okay, and they will also have some RBCs and inflammatory cells. Now what is the interplay mechanism? So this edema, the causes of heart failure, renal failure, and even malnutrition, hepatic synthesis, and nephrotic syndrome, they all have an interplay resulting in conjugating the effects of edema. Okay. So in heart failure, you already know there will be increased hydrostatic pressure and decreased renal blood flow, retention of sodium and water, and edema. Then in malnutrition, reduced hepatic synthesis and nephrotic syndrome, they will be reduced. What will be reduced? It's written here. Plasma albumin will be reduced with reduction in the osmotic pressure resulting in edema. Okay. So remember, renal failure, it will have the edema associated with renal is associated with two conditions. One will be sodium water retention and another is going to be reduced proteins. Okay. Now next is cerebral edema. So we have four categories in that: vasogenic, cytotoxic, interstitial, and hypoosmotic. Out of this, two are important, the vasogenic and the cytotoxic one. So as you know, in the brain, two things matter. One is the blood-brain barrier, the vessels and the cells. Okay. So vasogenic itself means the vessels are going to be affected. So what will happen? Because of injury, there is going to be gap formation within the vascular wall and movement of the fluid, okay, resulting in edema. And in case of the cytotoxic edema, the cells, which are the astrocytes, are going to be affected. Cytotoxic, okay, the name itself says cell and toxic things to the cell. So they will cause, there is going to be inflammation and again disruption of the membrane and outflow of intravascular sodium and fluid. Okay, so how will the gross be? There is going to be dilatation of the gyri and the sulci are going to be narrow. Okay. Edema is clear? Okay. Now hemodynamics of systems. Can you tell me what is hemodynamic? Hemodynamics. Murmur. All I can hear is a murmur. Hemodynamics. Anybody? Normal flow of blood through the body. So who will tell me how does the normal circulation happen? We will remove this. Now who will tell me how does the normal circulation happen? The cardiopulmonary circulation. Aorta and to the peripheral. Then what happens? From the peripheral systemic circulation, the blood is collected and it goes into the right atrium. From the right atrium, it goes to the right ventricle. From the right ventricle to the lungs. From lungs to left atrium, then left ventricle, and then to aorta and the entire part of the body. This is something which I expected from everybody. Okay, anyways, now you're clear about the normal circulation. So, any disturbance in that will lead to conditions like hyperemia, congestion, and hemorrhage. Okay, so first we'll know about the hyperemia and congestion. So, these are both vascular events, that is, they affect the blood vessels. So, this, if we consider this is a normal tissue and this is a portion of the tissue which is demonstrating the amount of blood flow through it, then both in hyperemia and congestion, it is going to be increased and the blood vessel will also be dilated. Okay, and then the blood flowing through the vessel is also going to increase in both the cases. So, this diagram you can understand it better. Normally, we can see that the blood in the arteriolar part and the venular part is almost equivalent. So, in hyperemia, what happens? There is an increase in the inflow. So, there is going to be dilatation at the arteriolar end, which will lead to increased flow through the capillaries. Okay, but the outflow is going to be normal. Okay, so with this, there is going to be there is going to be an increased blood volume within the capillary. This concept is clear? Okay, and in congestion, what will happen? Contrarily, there is going to be decreased outflow. So, if there is a decreased outflow, there is going to be, what will happen? what will happen to the blood? If it is unable to move out of the capillary, what will happen? Stagnation. There is going to be an increased stagnation. So it is more of a passive process. So what are the differentiating factors? First, we have to know the volume and the total blood volume and the vascular volume, both are going to be increased in hyperemia and congestion. And in the mechanism for hyperemia is active and often mediated by chemicals. That is, in which condition can we see? Some mediators which bring about vasodilation. Yeah, somebody said it correct. Yes, in inflammation. So, hyperemia is usually associated with inflammation. And in congestion, there is going to be stagnation. So, we know that the arteriolar side is affected in hyperemia and the venous side at the congestion. And usually the effects of hyperemia are local, but for congestion, it can be both local and systemic. So, with hyperemia, you know, we have already read it in inflammation part. So you can, if you are asked about it in your practicals, you can say, right? We have to know in details about congestion because it has more systemic effects. So what is congestion? It can either be acute or chronic. The chronic is more common and often it is known as chronic venous congestion. And the obstruction to the venous outflow, it can be local or systemic. Local examples are portal venous obstruction, as seen in cirrhosis of liver, in blasters and also tumors causing obstruction, and systemic in left-sided and right-sided heart failure. Okay, here comes the importance of knowing the normal blood flow circulation. Okay, to know the effects of this congestion in different organs. So, in right-sided heart failure, what will happen? The liver, spleen, kidney and peripheral leg veins are going to be affected. Okay, so in the right side, from which all organs do we get the blood from? All the peripheral organs, right? The blood flow happens from the peripheral organs and they are moved into the right side, right? So, with that you remember that all the organs are going to be affected when there is a right-sided failure. Okay? And in left-sided failure, which is the only organ from which blood flow happens to the left side? The lungs. Okay? Remember, left L, lungs L. Okay? In left-sided heart failure, there is going to be venous congestion of the lung. Now, what are the morphologies of CVCs of different organs? This is very important for your practicals. Okay, we will have specimens from this section. So, firstly, the liver. So, in this gross image, can you appreciate the mottled appearance of the cut surface? Yeah, some red dots and some yellow dots. Yes? No? Yes, so this resembles a nutmeg and hence the name nutmeg. Okay, so what are these red dots? These are areas of necrosis and they are depressed. They will be depressed, and the contrasting tan brown areas, these are the normal parenchyma of liver. Okay, so remember in CVC liver, the appearance is called nutmeg liver. Okay. Now what we'll see in microscopy? We'll see a zone of necrosis. It is going to be the central lobular zone, and along with that there is going to be hemorrhage and in the peripheral zones, and we can also see some areas of fatty changes. Okay, here also you can see an area of central lobular necrosis. Next is CVC lung. So even in CVC lung, the lungs will be enlarged and heavy and they will appear brown. Can you see this brownish appearance of the cut surface? And it will be because of edema, congestion and hemosiderin deposition, and this appearance is often known as brown induration. And in microscopy, what we'll see? We'll see that there are thickened alveolar septa, along with that hemosiderin laden macrophages. So this, can you see what is hemosiderin? It's a pigment which is derived from hemosiderin. heme, iron from breakdown of hemoglobin. Okay, so this pigmented macrophages, they are often termed as heart failure cells. Why so? Where do we see CVC lung in? In which condition? Which heart failure? Huh? Left-sided heart failure. Okay, and CVC spleen, there is going to be progressive enlargement of the organ with progressing degree of congestion, and the organ will be deeply congested and tense and cyanotic, and section surface will show a grey appearance. Now what will be the microscopy? We can see a thickened capsule with congested sinusoids, and gamma-Gandhi bodies can be appreciated. Okay, these gamma-Gandhi bodies, they have calcium and iron. Now moving on to hemorrhage. So as you know already, hemorrhage means there is extravasation of blood due to rupture of the blood vessel, and it can happen because of capillary bleeding as in chronic congestion or hemorrhagic diathesis, and the rupture of large artery vein can be caused because of vascular injury as in trauma, atherosclerosis, inflammations and neoplastic erosion of the vessel wall. So, these manifestations of hemorrhage, they will often depend on the size, extent and location of bleeding. So, this is again important, you have to know the terms. Hematoma means accumulation of blood within the tissue, and when the hemorrhage, they have a diameter of only 1 to 2 mm, they are known as petechiae. Purpura, it is more than 3 mm. Ecchymosis is more than 1 to 2 centimeter, and just like edema, we can also have this hemorrhage in the different body cavities, and that namely they are hemothorax, hemopericardium, hemoperitoneum and hemarthrosis. Okay, this I know you will all know about it. What is hemarthrosis? Hemarthrosis. Anything from the name that you can perceive? Yeah, when there is bleeding or hemorrhage into the joint spaces. So this is a gross image where it is showing a pinpoint hemorrhage all over the pericardium, which is known as petechia. Petechia means what is going to be the diameter? Yeah. This is hemopericardium, which is bleeding into the hemopericardium, bleeding into the pericardial space, which is seen in cardiac tamponade. This is, what do you think? Do you think the diameter is in millimeter? Ecchymosis, correct. This is ecchymosis because they are almost more than 1 centimeter. This is hematoma. This is purpura, where it is more than 3 mm but less than 1 centimeter. Okay. And this is an example of subconjunctival hemorrhage. Where do we see subconjunctival hemorrhage? In the subconjunctival space. Cause, etiology. Diabetes, no. Yeah, trauma or injury. Okay. So what is the clinical significance of hemorrhage? Why should we know about it? The clinical significance and manifestation, it often depends on the volume and rate of bleeding of the blood loss. So if there is a rapid blood loss up to 20 centimeter of the blood volume or slow losses of even more than 20 centimeter, it often doesn't have any adverse effect. But if it is more than 20 centimeter, it can result in hemorrhagic or hypovolemic shock, which we will deal with in the subsequent classes. And the site of hemorrhage is often etiological factors in formation of edema. We have 4 factors. What are they? Correct? Then? Yes? And yourself, the other 2? Hydrostatic pressure is done, oncotic pressure is done. What are the other 2 causes? That she has already said, hydrostatic pressure. There is increase in capillary permeability. Increased capillary permeability, and the other one, obstruction to, repeat, obstruction to lymph flow. Okay? Sit. Now what are the types of edema? What all you will include? Yeah, yes, all of that. Those will all come under systemic edema. Okay. Then enumerate the pathogenesis of systemic edema. In this you can write for renal. Yeah. Then because of sodium water retention it happens, and because of loss of protein. Then in cardiac edema, what are the three causes? Decreased cardiac output. What are the three contributing factors? Increase in the capillary hydrostatic pressure, sodium water retention, and because of decreased cardiac output there is going to be hypoxia, and there is going to be injury to the capillaries leading to increased capillary permeability. Okay, and you should also be able to write a short note on congestion. Now we'll move on to the MCQs. Okay, so from here, last bench. So a 65-year-old male with a history of chronic left-sided heart failure presents with worsening dyspnea, worsening symptoms, and then chest X-ray shows diffuse bilateral infiltrates with pulmonary edema. What is the underlying process? So here it is, we have to think via hyperemia and congestion. Yeah. Yes. Who said? C. You did not understand the concept of hyperemia and congestion? You understood? So it is because of passive congestion due to impaired venous drainage. They've already mentioned, right? He has a left-sided heart failure. So what will happen in left-sided heart failure? Congestion of which organ happens? Next, who will answer? Will somebody please volunteer? I don't want to call out. Yeah, this is easy, right? It's nutmeg liver. Okay. Next is 24-year-old healthy male accidentally cuts his finger while cooking. Area around the cut immediately becomes red and warm. This redness and warmth is observed primarily due to... Are these questions too difficult? They're just concept based. This is how you will get it in your entrance. Why? Now, can anybody explain this to me? So, this cut is basically a stimuli which causes, what is this redness, warmth, swelling? What are the signs of inflammation? What happens in inflammation? Hyperemia. So next is 50-year-old woman with advanced liver cirrhosis presents with significant pitting edema in both lower extremities and large amounts of free fluid in the abdominal cavity. This is generalized edema, and the most likely cause for this patient's generalized edema is increased capillary hydrostatic pressure. Who all thinks it is A? Comment. Okay, we have one person who thinks it's A. Okay, we have 4 people who think it's A. What do other people think? Yeah, it is B. Because it is liver cirrhosis. So liver is a major organ for... Okay, enough with the fun. Liver is an organ for... What happens in liver? Plasma proteins are synthesized. So, in liver cirrhosis, there is going to be decreased synthesis of protein and decreased plasma oncotic pressure. Okay. So, brown induration is seen in read all the options which is given for your MCQ. Okay, it is always the best option available. Pneumoconiosis, it is going to have black pigments. Bronchogenic carcinoma, it is going to be a space occupying lesion. And it is chronic venous congestion. I said it also while taking the class. The appearance is known as brown induration. Okay. Next is minute hemorrhages, 1 to 2 ml. Yeah, it is petechiae. More than equal to 3 ml. More than equal to 3 ml? Purpura. Okay. Any questions?